Wow. Hello, Kiran. Welcome to your section of the workshop. Can you just give me an outline of your current role and a little bit of experience in your past roles in terms of medical training?
Yeah, so in my current role, I'm a consultant child and adolescent psychiatrist working with eating disorders at the Ellern Mede Eating Disorder Outpatient Specialist Service. And I'm also education and training lead for eating disorders faculty of the Royal College of Psychiatry. Um, and really involved in developing this education materials with you so that we can start offering it soon.
Yeah, absolutely. And what a journey it's been so far. It's lovely to start sharing it, isn't it, with people? Really
It
exciting.
has exciting journey. Yes.
So I think one of the things that really struck me when I met you, Kiran, was around, I guess, your enthusiasm to train other doctors, especially, medical students and foundation stage doctors. Can you tell me a little bit in your previous roles, how you incorporated that?
So in my previous role, in the capacity of being clinical lead at the time for a specialist CAMS eating disorder service, and also a clinical and education supervisor for trainees, I was able to develop training for foundation trainees in our CAMS service. With the support of the training program director, the foundation training leads, the deanery, and this was in 2014 when foundation training was really getting into psychiatry, and it was a great opportunity to involve trainees into the assessment management of eating disorders. It was based actually also on the fact that we were seeing a huge influx of really serious presentations of young children struggling with eating disorders. And it was important for trainees to be aware of the presentations that were happening of such severe acuity, which could start off from the A&E or a pediatric ward, or have lots of red alerts. And therefore, it felt like every trainee from every specialism needed to know about eating disorders.
And that's the mammoth task of this, isn't it? It's that
Absolutely.
eating disorders can present in so many different forms, or like I say, on a gastro ward and
Yeah,
A&E.
yeah.
I suppose, how did you coordinate that? Which parties, which stakeholders did you have involved?
So developing the training pathways went hand in hand with also developing a specialist service, and the pathways with acute in the acute setting, my colleagues in the acute setting, such as pediatricians and gastroenterologists, was really vital. Senior members of the dietetic group, nutritionists, um, specialist nurses, commissioners, and wider stakeholders. And what's most important is that we involve families, carers, and young people in the service development, because it was so important to hear what they wanted, how they wanted to be assessed and managed, and what sort of support they needed to work towards recovery. So it was really important to involve everyone. I also had the opportunity of setting up the Junior Marzipan group, which meant that everyone could be invited, from this multi-agency, multi-liaison group, and everyone had a chance to discuss presentations. So, and trainees were very much a part of this.
Amazing. So you really had, that ideal kind of professionals, patients and carers all working together and, just being able to create something very meaningful, it sounds like.
And I think so, but I think that was mainly due to the fact that although we were a very small service of the very small critical mass, um, everyone was like-minded and very passionate about making a difference, and trying to train up more so that we had a big trained, skilled workforce for this.
Amazing. So I guess one of my questions would be, for those who maybe don't know so much about eating disorders, how can we convince them that this needs to be in the curriculum, or it needs to be part of training package for medical students and doctors?
I think, I mean, we know that eating disorders are severe mental illnesses with serious physical, psychosocial consequences. And it is really important that for everyone who's looking after them, that they are aware of what to look for, that eating disorders don't present as just one presentation. It is on a spectrum. So you will see all, they don't come in the same shapes and sizes. They're not exclusive to any particular type of, for example, you can have them across the age span. You can have them in all ethnicities, all class, socioeconomic strata, all sexes. So basically, it's important to know that there is not just one presentation of an eating disorder. And it's important that everyone knows that, because there are lots of myths that eating disorders, as there's one particular presentation that we know, or most people think of, and that's anorexia, and they think that there's nothing beyond it. So if you don't see just that exact presentation, people don't recognize eating disorders. And I think that's why it's so important to train.
It is. And, if I go from my kind of experience, when I first presented at the GP, my BMI wasn't that low, although my periods had stopped. And, I wasn't a typical presentation. And the other thing I was thinking as you were talking, Kiran, was that it's not often that people with eating disorders will say, I need help. Or, so I suppose it's how we train health professionals, doctors, to ask those really difficult questions in a sensitive way.
Yes, absolutely. Because very rarely we find that people will present seeking help for actual eating disorders. You might find that there are lots of different presentations. They might come for different complaints, and they might be vague complaints, for like tummy ache, or just, endocrine problems, or losing their periods, and things where people need to be quite vigilant and thinking about how they might present to a GP surgery. They could present to a dentist with various presentations, because we know that often you would find consequences of some of the behaviors, some of the compensatory behaviors associated with eating disorders, which could lead to serious consequences on physical health. You might find, emergency department might see cases which are presenting for various symptoms, but actually what's the hidden main sort of driving illness could be an eating disorder. So
absolutely. And I know we've said this before, but my aim within the training was to kind of have that mantra and impart it to doctors, to saying, think eating disorders in all different kinds of situations, just so that it's somewhere filed a bit further around the front, so that actually they piece things together and realize actually there could be an eating disorder occurring here.
Yeah, no, absolutely. You said it. They don't fall into any specific category. They could come in any way, and it's important to know that. And that's why I think after the GMC report of Mind Matters and that was published, I think that was in 2019. One of the things that was kind of recommended was more training for medical students in eating disorders, because it was felt that there were, things like BMI were kind of guiding professionals to decide whether service could be offered or not, and that absolutely wasn't the case. We know that you could have a reasonable BMI, but actually might be quite seriously ill.
Yes.
So this is
absolutely. And one of my classic phrases is, you can't measure someone's distress by what it says on the scale. It's that preoccupation, isn't it, of thoughts. So, and I think that's, I know certainly in terms of access to treatment, I think that's a key message coming through in regards to eating disorders and understanding, for sure.
Absolutely.
So Kiran, tell me, I joined the project a bit later, I think. So tell me how you ended up, well, did you give volunteer for this project, or I don't know, maybe you were asked.
Well, as you know, the Royal College of Psychiatry have been very sort of keen on education and training for eating disorders. And when I joined in 2017 as the education training lead, I think one of my biggest passions was to start working just to make sure that everyone knew about eating disorders, and it got taught in many medical schools. So one of the things that I presented was a business case to the faculty, which could include outreach training. So um, taking the expertise in eating disorders out to various medical schools and training people of going to places and actually conducting 2 days of intensive training with workshops and role play and really doing meaningful training. And Andrew Radford, the CEO of Beat, was present there, and he was really, really interested in taking this forward. So the next thing we knew was we were talking about it seriously and developing ideas, and we spoke to Maudsley and found out about the various sort of sim training and how we could incorporate that into it. And then I also had the opportunity to facilitate a Pan London Foundation Training Day with Professor Kauzoon, so in London, and that's where we started to develop Sims, which had really good feedback.
Yeah,
So
and I'm interested in the Sims because we typically hear of OSCEs that are a method of, I guess, examining doctors, aren't they?
Yeah.
Can you run me through kind of what the differences are between the OSCEs and the simulation training that you've written for this project?
I think simulation training offers the opportunity to actually do a whole narrative. So you get a feel of the whole presentation, which is exactly how it should be, because the one thing we need to know is that, eating disorders go beyond numbers. They go beyond the weight, shape, size, calories, and all of that. Beyond all of that, there is this individual, there's this person with their own strengths, their own achievements, their own lived experiences. And Sims, I think, are able to bring that to life. So they actually also allow for more interaction, more role play, more kind of, meaningful learning. So rather than just going through a um, very small objective structured clinical assessment, you can go through a slightly more detailed one. And again, it kind of, it is something where now the two Sims that we have developed, those are such that one is a young lady and one is a young man, and that shows that that eating disorders present in both sexes, and that people can present very differently. Again, both of them have not presented to anyone saying that they have an eating disorder. Both of them have actually turned up in crisis to the emergency department. So the foundation trainees based in the emergency department would be the first to actually assess them, which means that they need to know what to look for. Because as a wise man said, that your eyes cannot see what your mind does not know. And therefore, if the foundation doctor or the junior trainees, who would be the first people to see them, knew exactly what to look for, and look at the presentation, the physical aspects, the blood investigations, the cardiac parameters, what is it that they would worry about? And if they worried about something, who would they talk to first? What would be their first port of call in terms of doing a referral or speaking to their senior colleagues? For example, somebody might present with a heart rate of 40 with an eating disorder, which falls into the red alert of junior marzipan or marzipan, which is management of really sick patients with anorexia nervosa. It's the college report. And that gives you, how you kind of look at risks. So somebody might say, oh, if you're exercising, that's fine. You can, you don't need to stay, you can go back. But actually, it could be a really real red indicator for risk. And how do you know that? So you need to talk to someone senior. You could get in touch with specialist eating disorder services, with nutritionists, gastroenterologists. But how would you know if you didn't know anything? So it was trying to get all of that into the SIMS.
Yeah,
Really.
and I think, from writing the e-learning modules, we've got some really good practical resources in there. And I think, that certainly from what Ellern said, and we'll hear from her, she had this vision of, there's a junior doctor on a night shift, what needs that information, and hopefully they would find, some of these assessments that, you've created, and the eating disorder pocketbook, which has got a good summary of a lot of the marzipan information on it. And I guess we wanted them to have these practical resources, didn't we?
Absolutely. And actually, that's a really good point you make, because one of the things when I was working with junior doctors is that we sort of decided that we approached the A&E department, and the foundation trainees who had already worked there knew that they didn't have any such resources when they were actually doing an A&E placement. So they said, could we then take these and laminate all the pathways, the sort of risk pathways, and put them up on the all the workstations or the offices, so that supposing we were faced with these kind of crisis situations, we could look it up and sort of say, who do we call now? What do we do immediately? And that remains with them, because there'll be new trainees rotating through and everyone needs to know it. The other thing that one of the foundation trainees I worked with also did was I supervised an audit with him, and he tried to audit the practice of how many GPs knew about junior marzipan, how many GPs knew what to do if they were faced with risk. And then we sort of sent out all of the pathways to them, and then they were put up on their main education sites. So these things are quite important as well. Building in research and training
Amazing.
into it is really important.
So really innovative work there, Kiran. And how would someone go about creating an audit of GPs, for instance? So I just think that sounds so vital in terms of outreach, from eating disorder services.
Yes, and it was very very well received, because I think everyone felt that it's a caring profession. Medicine, nursing, all of us as professionals, we are in a caring profession. Everyone wants to do their best, but you need to know what to do, and everyone needs the support. And this is how we can, we keep training and educating and learning ourselves, and that's how we actually spread,
the word,
the learnings, spread the word. Yeah.
So obviously in the SIMS, we want to draw out, kind of risk assessment, physical signs and symptoms. What about kind of the more kind of psychiatric side of things and mental health and all those other factors? What are we trying to draw out from the SIMS in terms of those?
That's a really valuable point, because again, within the SIMS, as you will see, especially in the second SIM, there are comorbidities. And what that means is that eating disorders don't come as pure sort of eating difficulties or disordered eating. They're often associated with other severe mental illnesses like depression, anxiety, obsessive compulsive disorder. And all of these need to be recognized, so that you don't miss anything. The other thing to remember is sometimes if somebody is suffering from depression, they might lose their appetite, and that again means that they might stop eating. That's different from an eating disorder, because in eating disorder, what would happen is that due to starvation, their mood would be low, because that's a consequence of starvation alongside everything else. And then it is about kind of seeing what is the appropriate mode of management and mode of treatment. And sometimes they coexist, and sometimes one comes before the other. But the most important thing is to know that we are dealing with one individual, a human being who has got lots of different
and that really comes across in your assessment, is to look really comprehensively at the whole person, the whole picture, family background, social aspects of life. And that's why I think your tool's so great, because it's so comprehensive. And I guess, from what I know of the OSCEs, to try and do that in, how to perform an assessment when you need to get that information, I can kind of see why the scenario-based training
Yeah.
is much better, to give that space and time, and to be able to think through how to communicate, because that's so key, isn't it, in terms of training
Oh,
doctors, I
yes.
guess.
Oh,
What
yes.
kind of tips, or how do you instill those communication techniques around eating disorders?
So you mentioned the assessment tool, and the reason we included that in the resource pack was because we felt that, you know, the sims are great, but people would be thinking, oh, but how do I ask these questions, or how do I approach someone? And people often tiptoe around this illness. It's almost like, you know, having an elephant in the room and everyone's too scared to ask. But and then what would happen is that they miss some really vital information. So therefore, through this assessment tool, it takes them through just understanding the person, trying to get to know what who they are, you know, in terms of what defines them, what sort of things they enjoy, but then slowly getting into their concerns and the eating difficulties, and then thinking about the cause of the illness, and what kind of predisposed it, what may have precipitated it, what might perpetuate it, and what sort of positive factors they have already as their strengths that may actually counter all of it and bring them out, you know, positively towards recovery. So these things are important, but equally also then to think about, how do you ask about the weight history, because it's a very sensitive topic, and you can't, you know, you can't just ask it in a way that might put the person off, or make them upset and disengage from you, because then you've lost the whole um, you know, the engagement completely. So then that, those kind of communication skills, sensitively but with courage. So
Yeah.
not tiptoeing so much that you miss out on asking vital information. And then how do you ask about body estimating patterns? How do you ask about nutrition and nutritional history, and calorific intake? And then go on to ask about family support. Who is in the family? Who looks after you? Because ultimately there's going to be a lot of support required from family members, who are the best support network for you know, people struggling with it. And then thinking about personal history, what sort of personality types they have, what their temperament is, so that we can work with the individual unique attributes that everyone has.
Mm.
And then at the end of it, um, prepare a biopsychosocial formulation, which then allows you to look at what sort of strengths can help that person um, work towards recovery. So it's kind of a comprehensive tool, but this is a specialist tool.
Mhm.
From that, what could happen is that with that resource in front of you, it could offer a template to think about, how do I ask about this particular topic? So what we did was, together we divided it up, didn't we,
Mm.
into various sections, so that people could do role play on those sections as well within the sim training.
Absolutely. And I think, you know, we've also got lots of themes of lived experience through the modules, haven't we, and through the simulation
Yes.
training. And, you know, in the videos where we've got about a few, you know, 4 or 5 of our ambassadors talking about their interactions with doctors, I think you've highlighted so much, and all that they need to know, and then that engagement, just how important that first interaction with the doctor is,
Yes.
and all those things you need to think of. And I suppose, you know, that's, yeah, I think that's what we've really, well, you've done really well to get across, because that's what we're hearing from people with lived experience is, if someone blows it in that first interaction, it can really set you back in terms of then picking yourself up and coming back and asking. So I think, you know, you've really nailed it in terms of saying, think about all these
Thank
things
you.
and how you communicate them, which you know, is going to make
Yes.
such a difference.
And actually, you know, most importantly, not being afraid to ask the right questions, because this is a serious illness. It is a very, very serious illness that could lead to severe morbidity and mortality, in terms of all physical health, psychological health, psychosocial well-being, and you know, looking at the insight, the capacity of the person, the ethical legal aspects of it, safeguarding, all of that is really, really important to get in. So whilst we are going to be very sensitive about it, it's important to have some knowledge about it, some basic knowledge of nutrition, about how, otherwise how would we know what to look for? If unless you know that this is what is required in a good a sort of healthy meal plan or whatever, which is going to be helpful towards their physical well-being, how would we be able to ask those questions?
And I remember you saying about this new book that's also come out, New to Eating Disorders. We thought actually that ties in some really good information as well that we think doctors would find really beneficial.
Absolutely. So the Royal College of Psychiatry, two of my colleagues, Dr. Kaz Naman and Dr. Jane Morris, have developed this fantastic book, which is called New to Eating Disorders. And that actually contains lots of various presentations and all sorts of things to look for. So it is really fantastic for trainees to look at that as a very useful resource.
Amazing. So I guess final bits of advice then, Kiran, how do we get this training into medical schools? How, what would you be your advice to get this into the curriculum?
So absolutely, this eating disorder training has to be firmly embedded into the curriculum, into the GMC curriculum, so that it is actually something that gets tested on. And for that to happen, I think we need to be very proactive in going and approaching medical schools and going and talking to those clinicians or professionals who are interested or passionate about it, who want to actually offer the training, but also to build ties with their local eating disorder services so they can find some experts who can come and talk to them. And also the tools that we are developing, the education tools, to be able to offer those to medical schools, to offer training. And from the Royal College of Psychiatry, we would be very happy to work alongside you, to offer this and to kind of come and do some risk assessment management training parts of it, medical management, psychiatric management, and, join up with you and the medical schools and stakeholders. So building in young ambassadors and family, because those voices are so powerful. I found that, lots of young people would join me in training, offering training days for GPs and psychiatric trainees and, medical schools even. And actually that was the best way of delivering the training, because nothing is more powerful than the voice of these individuals, young ambassadors. And I think that's how we need to build our training up together, and just approach people and ask them that we want to do this.
Amazing. And I think that's such a good idea in terms of, getting the eating disorder services on board, maybe near medical schools, location. Exactly. I think that's such a great idea that we could pursue, in terms of getting this training out there and into the curriculum. So finally then, Kiran, I guess one of the things I've really noticed about you is that you work very collaboratively with your patients and creatively. Could you just tell us, what for a few minutes, just about the creative group that you set up? Because I think it's quite unusual for a psychiatrist to be able to do that with young people, and I think people would like to hear about it.
Oh, thank you. I mean, yeah, that actually is truly close to my heart, because I feel that, as psychiatrists, one of the greatest privileges we have is to be able to be part of that recovery process. The therapeutic process is so important. It's so important to be allowed into somebody's life in a meaningful way, where we feel that we can help them towards recovery. And just simply doing a mental state examination or offering a medication review is not the be all and end all. Especially for me as a child psychiatrist, it was really important to get to know the young people I was seeing. And most of them could only do evenings, and they wanted to be part of a group that I thought would be quite helpful. One of the young people who had recovered and went on to complete their art degree in Cambridge wanted to join me for this. So between the two of us and an assistant practitioner, we developed an evening group for young people. And following a focus group, it was identified that there were certain themes that they wanted to work on. Most importantly, they said they wanted to learn how to respect themselves. So I worked on it, and it became the Respect Me group. And what that means is actually accessing some of the themes of experts who have already worked on CBT and CBTE, mindfulness, compassion focused therapy. I tried to build into this model each of the things that they wanted to work on, the young people wanted to work on. So R stands for resilience building, E stands for eating choices, S stands for self-esteem work and self-esteem building. The P stands for psychoeducation, and then you have E for emotional regulation and working with emotions and learning how to develop emotional adaptive coping mechanisms. And then you have C for self-compassion through creativity. So using lots of creative medium and non-verbal expression, how do you kind of learn to incorporate that? Because we know that creativity, compassion, and emotions all live in the same parts of the brain, and if you can increase creativity, you can dampen the anorexic cognitions and distract from it, and all of this then towards trigger recognition. So the T stands for trigger recognition and building a toolbox of resources. And we use mindfulness techniques and motivation enhancement therapy towards it. So that's why it's called the Respect Me model. And it's practice-based evidence more than anything else. I've not been able to do anything in terms of publishing it yet. But I think what would be really important is to know that that's how you get to. And in fact, during those groups, what I found was that I was able to observe anxiety, sometimes severe low mood, sometimes really severe anorexic cognitions, sometimes even, a level of PTSD with certain things, and you kind of look at that, OCD, even just doing things in a so you observe perfectionism and all of that when you actually get a chance to work with people creatively. And I found that a really, really helpful experience, and had excellent feedback. So it's something
Sounds
that
amazing. And I think to me, it's just like you were looking at the whole picture and building up that resilience in different areas of their lives. I think sometimes when we look at the eating disorder so much, it's like staring at the sun. I don't know about you. It's like, actually, let's look around and build all the things up in the person's life, those tools that they already have. And then the
already
eating
have.
disorder will fade within time.
Absolutely. And when trainees joined these groups, they actually became more they felt more confident in working with young people who were struggling with it. Because prior to that, they said that they were really scared and they were really worried that they would do the wrong thing. And therefore, they felt that it was best to hand it over to somebody else, because what if they failed the person? So it was more about not knowing what to do, and therefore really being afraid of it. Was all to do about how do I deal with this serious illness. But actually, when they got to know the person behind it, it made it so much more meaningful in such a way that they could work together collaboratively. They developed great therapeutic engagement.
Yeah.
And they came up with some really good ideas themselves. So the trainees were coming up with some wonderful ideas and working very well together within the group. So it was a great training experience as well for them to be part of it.
So I think sometimes, I think you're absolutely right. The fear and anxiety involved in working with eating disorders can sometimes take over, and it happens to all of us now and then, doesn't it? And I suppose it's it's dialing it down and remembering, just look at the person, develop that relationship, that contact with them, and maybe that needs to come first, and then ask all the questions.
Absolutely. And the eating choices as well, they were able to do some role play, and they were able to actually draw some of the food groups, which was so worrying for them otherwise, and think about various types of cooking recipes. And in the part of creativity, we did some dance work as well. So they came up with some amazing dance, and they even wanted to learn a little bit of Bollywood. And so
Amazing.
it was kind of really, and they wanted to engage really well. Some of them who were really seriously ill really engaged well through these groups. And the other thing they did was they went and presented it to one of our local MPs, and said that, where are the underweight pathways? We need underweight pathways. Everyone talks about the overweight pathways and obesity, but we get forgotten. And then schools then, obviously because of the societal pressure that's around us about what's good food and what's bad food, which keeps changing every day. Parents don't know what to do either, and everyone is so confused about it. And so our schools, so people were getting weighed, and it was quite distressing, which was triggering lots of anorexic thinking where there wasn't any before. And these young people were saying, please start some underweight pathways in our schools, stop weighing us in schools. So it was quite a powerful medium for people to
Yeah.
stand
I
up.
think you
And
might have people knocking on your door after this, Kiran, for that course. It sounds amazing. And thank you for sharing, because I just think, sometimes I don't know about other people, but I have a bit of a stereotypical view of psychiatrists, quite wrongly, I would say. The more and more I meet you and other psychiatrists, I learn more, obviously loads more from you. But I think to hear someone working creatively, I think it's really inspiring. So thank you for sharing with us.
oh, that's really, really kind of you. There are lots of child psychiatrists, I think, are doing some great, all psychiatrists are doing some great work. So, but thank you. It has been an absolute privilege to be a part of this journey of developing educational resources. And I'm sure there's lots of work for us to do, and we will continue to do it.
But we've been a good team along the way, for sure. We
Great
really
team,
have.
dream team, absolutely great team.
Well, thank you, Kiran, so much for your time today. And I know people might ask me questions, but I can always forward questions to you as well over the conference time. So
It's
thank
a
you very
pleasure.
much.
It has been a great pleasure. Thank you so much, Jess. Thank you.